Good afternoon. This is Dr. John Bennett broadcasting from sunny Miami for Radiologist TV. Fike Shake is working at the hospital. Some people have jobs. We have a talk today with Ayden Jacobs, the imaging physicist and the radiologist. And in addition, we have a guest. We'll let him introduce himself and tell us what he does, and then we'll turn it over to Ayden. Good day. Good day, Imran.
Hey, how you doing? Sorry, I was on mute. So yeah, I'm a abdominal radiologist and informaticist. I'm doing a fellowship right now at University of Maryland and also at Hopkins, and I'm excited about this talk. Should be very interesting.
Very good. Welcome, Imran. Okay, Ayden, it's all yours.
Hey guys, so welcome from LA. We're going to be discussing the relationship that exists within the clinical world between a clinical radiologist and an imaging physicist. So I'm sure Imran, through his clinical work, interacts with medical diagnostic physicists, imaging physicists, and then on the flip side of that, you have as well the radiation therapists who will deal with or interact with various types of radiation physicists as well. So what we want to explore today, and the way that we kind of do this is short talks that go into detail, a little bit more detail every time. So what we want to do is describe the basic function of an imaging physicist as it relates to the job of a diagnostic radiologist. And being that we have Imran here, that'll be nice because we can, get his input into how he feels that field can be improved and how that relationship exists on various levels. So to begin with, I think, if we take a look at, let's say we have a patient's coming in to get either a CT or an MRI or whatever, and let's look at this through the lens of the patient. It usually seems as if a tech takes you into a room, takes an exam, go back to your regular room, and the radiologist behind the doors is kind of reading what's going on. Comes out with a diagnosis, the patient's informed of this diagnosis, and then the attending physician, along with the squad, kind of goes back and works off of that initial diagnosis given by the radiologist. So what's interesting in the development of imaging is that as time has gone on, the ability for a radiologist to specifically diagnose certain disease states becomes improved by the introduction of an imaging physicist. And this is the point, or this is the crossroads that I think would be nice to explore. Meaning, what is it that the imaging physicist can give to the radiologist to help him or her improve upon the diagnoses of their patients? So what's happening is that we're trying to increase image quality to some extent. Now, a radiologist is trained in a very clinical manner, although their boards and whatnot do include the physics of imaging. A radiologist is being trained very specifically into how do I diagnose this patient, giving the images in front of me. How do I delineate X organ from X tissue, from a microcalcification or tumor state or emphysema, etc. Very, very complex job. One of the hardest jobs in the hospital is to be a radiologist. And the manner in which they're helped, so to speak, is through the imaging physicist. So this is kind of where I think, one of the fields of medicine which are getting greatly improved upon is through the interaction between the radiologist and the imaging department in terms of the imaging physicists. Because what happens is the imaging physicist is able to manipulate, so to speak, the standards of the imaging devices and technologies in order to better obtain an image for the radiologist. So it all comes back to what does the radiologist need, and how can we give them what they need in the best manner possible for them to properly diagnose the patient. Now, as time has gone on through the 70s, the 80s, the 90s, etc., we've seen these two domains of medicine interact in an interdisciplinary fashion more and more and more. And the intercommunication between the fields of radiology and imaging physics is paramount to better development of diagnostics in medicine. At the end of the day, we have to think about what is it that the radiologist is trained in, what can he and can he not do, and what is the imaging physicist trained in, what can he and can he not do. Now, a radiologist is brilliantly equipped to look at an image in a way that nobody else in the hospital can. Nobody else in the hospital can look at an image with the precision that a radiologist can. An imaging physicist cannot look at an image and give you a diagnosis. They can't. They don't have the clinical expertise, and they don't have the ability to correlate an abnormality on an image with a given clinical manifestation. What an imaging physicist can do is enhance the image in a variety of ways by which the radiologist can then say, okay, this is an image I can use, or very frequently you'll hear radiologists tell the imaging department, this image sucks, can't see it, can't utilize it. And the imaging physicist is able to manipulate the image in such a way that it stays true to the anatomical features of the patient, but yet is able to give a deeper insight into what's going on with the patient and the related diagnosis. So, John, is that making sense for a broader audience, so to speak, about how that relationship exists?
Yes, it does. It does. It's kind of like in many areas of medicine, they have certain doctors or certain PhDs that have a sound understanding of the internet, and they're able to more effectively leverage the effects of the advances of the internet into medicine. Is that what you mean?
Well, so not so to speak for the internet here, but is that you're using that as a metaphor?
Yeah, as it applies to any specialty, not just radiology, but cardiology, whatever, dermatology.
Yeah, that's exactly right. And I'm sure Imran could, if he probably sees it on a daily basis.
Yeah, definitely. I mean, we can't. The radiologist many times, the tools that we use that are vital to our profession, imaging, whatnot, it needs to be fine-tuned and by an imaging physicist, right, to make sure we're not giving too much dose. There's not dose creep. We're giving, using the correct protocol. We're doing the best we can for the patient to not to use our images, precisely with good image quality and reducing any potential harm from radiation or from time spent in a scanner and all the other detrimental effects that can happen.
Exactly. So that's a good point, Imran. And going off of what you just said, so for example, the government will release protocols by which these different types of equipment states should be utilized to obtain images. Radiographic techniques, MRI protocols, how should the technologists be doing their thing, etc. It all comes back to two things. One is patient safety in terms of radiation dose, and then obtaining the best image so that the radiologist can actually get the best diagnosis possible for their patient. Now, Imran brings up a really good point in terms of the dose given to the patient. So, for example, if we look at something that's happened this year, the committee which gives us information about mammographies, after a decade or so of sticking with one criteria, they've switched to another one which is a little bit more loose. Came out a couple of weeks ago in terms of, well, if you're over 40 and you want to get a mammography, you could. We're not pro it, we're not against it, etc. Whereas previous to that, it was every year, if you're over a certain age, you should be getting one. So we see that things are changing rapidly in the imaging environment, and one of the reasons is because we're starting to understand more and more about the effects of dose on different types of tissues in humans. So we want to be able to make sure that, if your radiologist is saying, okay, we need this type of imaging in order to get a proper diagnosis, how much dose is that giving to the patient, and in what ways can we decrease the dose to that patient? This is where an imaging physicist can use their knowledge of dosimetry to liaison with the radiologist and their team to come up with a method by which you're giving the least amount of dose to the patient and at the same time obtaining an image by which the radiologist can properly diagnose the patient. So that's one domain in which we look at, what is going to be the radiobiological effect of the imaging technology on the tissue that we're looking at. Because as we know, the interaction with radiation in tissue can lead to cancer at a certain extent. But the interaction of radiation with tissue is primarily what's giving us these wonderful images that we can use to diagnose patients. So it's a pull and a push, and we want to be able to do it to the best way possible. And American medicine has developed in such a way that, okay, the way we do this is we train a select group of people who are inherently assisting the radiologist team to develop a way by which you can decrease dose to the patient, get the best images for the radiologist, and thereby, come out with a succinct manner by which we can provide quality healthcare. Interestingly enough, and also off what Imran was saying is, in a day and age in which we're seeing physicians are ordering more and more imaging tests, so you're going to have patients exposed to radiation more frequently than we did 5 or 10 years ago. So this is where an imaging physicist can introduce their own methodologies to tweak the systems to say, okay, this is what we can do in this particular case in order to, decrease the dose given to the patient, but yet obtain an image. Sometimes you can say, well, we can't image this patient because they were imaged X amount of time ago, and this goes beyond the protocols of either the hospital or international regulations. So this is the basic interaction between the radiologist and the imaging physicist. But being that we have a radiologist here, Imran, let's ask you, just out of curiosity, do you have any FaceTime with imaging physicists in your day-to-day activities?
Well, I guess not in our day-to-day. So, there's quality checks, quality assurance, things like that kind of go on a department level. But as for the radiologist, day-to-day, usually when you see the imaging physicist or someone, that's usually when there's some major issue going on where you have to, ask for dose or, when there's like a sentinel event or something like that. But usually on a day-to-day basis, there's not interaction, which is unfortunate.
Well, one quick comment, Imran and Ayden. What kind of a background does a radiologist have to have in physics? Is that a prereq, or do you kind of learn it in your residency and internship? You learn basic imaging physics?
So for our board certification, we do have a large portion in physics,
Okay.
but I guess it's more so that we understand how our machines work, we understand how to reduce dose, and we understand the language, so we can consult with our medical physicist.
Okay.
Right. So I think they structure the educational parameters between physicists and radiologists in such a way that there's a bridge which allows them to communicate. Like the imaging physicist has to be able to at least understand the basics of what a radiologist needs, wants, and understands, and vice versa. So a radiologist doesn't need to know the depths of the physics of imaging. And on the flip side of that, the imaging physicists, they don't know the depths of clinical diagnosis. But there is a common denominator by which they can speak about in terms of the basics of physics and the basics of diagnoses and the basics of medicine. As opposed to having a nuclear physicist, which they can probably figure out, the proper mathematical equations for running these imaging techniques. American medicine has developed, diagnostic imaging residencies and physics residencies in which you're taking these physics students and you're training them in a manner which is directly correlated to clinical medicine. So in this way, they're able to correspond with the clinical field by inculcating physics and medicine together. And this is, a great aspect to imaging for the future, because you can't expect the radiologists with all of their duties to also take upon themselves the understanding of the depths of the physics of imaging. But you can educate a group of people in each hospital, and sometimes it could only be a handful, to assist them in this way. So I think this correspondence between imaging physicists and radiologists goes a long way. And you'll have it in all different forms. You'll have it in, thoracic imaging, musculoskeletal imaging, neuroimaging. All subspecialties of radiology will have an imaging physicist, maybe even the same one, who is able to assist with, the techniques by which you can image properly and the doses given to the patient.
One comment, Ayden, Imran is doing a combined fellowship of body radiology and informatics. Are there any combined fellowships of imaging physics and radiology? Do you know of any? And if not, do you encourage the creation of such?
I mean, if you wouldn't be a practicing radiologist and a practicing imaging physicist. They're two. It's like being a butcher and a grocery store cashier at the same time. Now, is it possible to have someone who's knowledgeable? Yeah, you have a lot of MD PhDs in radiology who their PhD is in imaging physics. So to that extent, those guys you don't need to give them an imaging physicist, really. They know it backwards and forwards. Mm-hmm. But they're trained through a clinical residency for diagnostics, really, which is, you have to think about the complexity by which a radiologist deals with. I mean, I'm almost amazed, as much as I am of radiologists as I am of neurosurgeons, because radiologists need to be able to look at any organ in the body and delineate healthy tissue from not. This is just the simplest way to say this. What is the disease in this organ? But they're covering the entire human body. Cardiologist is looking at the heart, neurologist at the brain, oncologists at blood. A radiologist has to be able to know the determining factors to diagnose every single disease in the human body. This is, a multi-specialty field that they just throw under the branch of radiologists. So it's fascinating to how much these guys know. They probably know more about the human body than anyone else in the hospital. Mm-hmm. Which is I don't think people. I've only learned this in the past year or so that. Mm-hmm. We did a health economics analysis on radiologist salary, meaning compensation for radiologists is good, it's gone down a little, it's gone up, fine. And I wanted to understand, what is it that the radiologist does that validates compensation at this level? And when you go behind the scenes and realize that no other area in the hospital can really function properly without the radiologist. So it's kind of like a brain or a hub of the hospital, because a diagnosis in orthopedics has to go through the radiologist, but a diagnosis in cardiology and neurology has to go through radiologists as well. Mm-hmm. So you're looking at every single department in the hospital going through a center in which the diagnostics comes from. So this is a fascinating area of medicine, which I think radiologists are looking to kind of, reclaim. There's been a lot of published articles and literature and conferences about how can the radiologists reclaim their fields by, other fields trying to minimize them or take over, or teleradiology, at which hospitals can just send out the images to India, Israel, Pakistan, etc.
Let me ask you, what is the day-to-day responsibilities of a medical physicist?
What are they?
Yeah, what yeah, exactly.
Yeah, that's a great question. So it depends if one is involved. So right now in American medicine, you have imaging physicists, like diagnostic medical imaging physicists, and then you have physicists who are therapeutics. So therapeutic medical physicists will primarily interact with radiation oncologists, and their job is to plan dose treatments for each patient in the hospital. So what happens is, let's say you have a mother who has breast cancer, but she's pregnant. So the radiation oncologist will come to the therapeutic physicist and say, okay, this is the situation. We have a fetus, we have a mother, 6 months. I want to irradiate with this type of therapy. What is the proper way we can go about building this treatment such that the fetus doesn't get, dose or, fatal dose? So that would be the job of a therapeutic physicist, meaning it has nothing to do with imaging. They don't interact with radiologists much. It's more about how do we minimize dose to a patient. So the radiation oncologist is saying, I want to give this type of dose to the patient over X amount of time, and then the therapeutic physicist is going to have to come up with a plan to do that efficiently. So that's their day-to-day. An imaging physicist, on the other hand, is directly correlated with the Department of Radiology, such that going from day to day, it's more about calibrating machinery, making sure that the machines are each working according to the manufacturer standards, ensuring that the doses are within the appropriate range that are given to the patients. And on the flip side of that, an imaging physicist who really develops a relationship with the Department of Radiology should be working closely with the radiologist to help them obtain the best and clearest images possible. So there are techniques which PhDs in imaging physics learn to a great extent, whereby they use mathematical models and other types of fancy things by which they're able to obtain the best image possible in terms of quality. So noise to resolution, spatial resolution, things of that sort. It's not as simple as pushing a button on a computer. It's more manipulating the system and working with the system to obtain the best image possible. So I would say those are the two day-to-day activities, or the two categories for physicists in medicine.
Yeah, I have a question, and my background's in ER. It's not in radiology. But when you give a study like a CAT scan, does every CAT scan have exactly the same radiation dose, or does it vary from CAT scan to CAT scan and day to day? Or is it constant, X amount of rads and that's it?
Yeah, that's a good question. So the machinery should be giving a standard
calibration.
Yeah. But the imaging, that's the responsibility of the imaging physicist to ensure that it doesn't change. Recently, I was informed that it's not unusual for the calibration to change every single year, meaning the imaging physicist tests the machinery, updates the machinery, at least on a yearly basis, to ensure that the dose given to the patient for this imaging technique falls within their guidelines.
Mm-hmm. Okay, yeah. There are some platforms that measure. There's some company from Poland. I interviewed the guy that measured the radiation that someone gets, and they actually accumulate that. And also, there's some kind of platform. Maybe you guys could comment on this. There's some kind of program or platform where the amount of radiology studies in a patient is logged on the cloud, so that from the time you're a youngster onwards, every radiology study you have is logged in, so that anyone ordering one is able to see how much. Have you guys heard of any platform like that that kind of keeps track of how much radiation the patient has got? from prior studies?
Yeah, there is thought on how to have a cumulative dose for a patient. However, you're never actually measuring. I mean, Ayden can probably comment on this. You're never actually measuring the actual dose. It's more of a dose based on a phantom produced from that scanner, and there's a way to track that. So it's not actual dose that the patient is getting, but it is a way to kind of measure how much imaging a patient is getting.
Well, is there some kind of log kept anywhere? I know there probably isn't, because you know, if you go to another city, they won't know that you had a CT last year or 2 years ago, whatever.
I think some hospital systems like the VA are thinking about utilizing something like that, but I don't think anything from what I've seen. I haven't seen any. Ayden might know better, but I haven't seen any hospital actually track it yet. I mean, until it's passed legislation, I don't think we'll be seeing it system wide.
Okay. No, I think some private individual or maybe a doctor made some kind of app or platform that had you log. I don't think it's hospital responsibility, but the patient himself, or every study he had. I guess they have to, you know, upload it to the cloud, so that no matter where you go, you know what kind of radiology studies you have had. That sounds like a good idea to me. Don't you guys think so?
Yeah, people are trying to develop this not just within scans you've obtained, but now with these full body imaging at the airports. So people want to be able to scan, you know, how many CTs did you have, how many MRIs did you have, and how many flights did you take.
Right.
There is not a standard hub base that goes throughout all of the institutions in America telling the physician that. However, you have your medical history. But the question is, has it captured really what's gone on, you know, in terms of your imaging history? Have you, let's say you move from state to state, does that get transferred over? Many times, let's say you go in to get an MRI, they'll ask you, you know, when was the last time you had one? When was the last time you had a CT? But the idea that you're discussing about building some sort of platform, you know, theoretically it would be awesome, but the issue would be that that's patient reported itself, meaning the patient keeps track himself of their imaging back, you know, which, yeah, would be interesting, but if we could get patients to do that, then we can get them to take their medicine also.
Well, maybe somehow it could be uploaded to the person's personal EHR, the personal health record. But as we all know, certain systems, it's inoperable. One hospital won't use the same personal medical record of the other. So that's a problem of interoperability between different systems.
Yeah, that would be definitely a good idea. But I don't think anyone has developed that yet.
No.
I mean, there's a lot in the news about, you know, reducing dose. So these things are in the pipeline. You know, these things, tracking dose and imaging utilization, is in the pipeline. These are things that people are thinking about how to effectively track.
Yeah, from the time you're born onward. So, okay, very good. Anything else? Anything else?
The basics of radiologist and imaging physicist. Imran, thanks for joining us, man. It was good to have you here.
Yeah, definitely.
Okay, Ayden, keep on rolling, and we'll get that Elvis impersonation sooner or later.
Yeah, take care.
Okay, thank you. I'm Imran.
Yeah, take care.